Good afternoon and welcome to this session on the topic of involving people with dementia. My name is Ana Diaz. I work as project officer at Alzheimer Europe. Most of my work is working closely with the European working group of people with dementia, as well as being very much involved in the public involvement activities of the organization. So it's a real great pleasure to be chairing this session on involving people with dementia. We have 5 speakers with us today. Some of the presentations will be live and some of them will be pre-recorded. I'd like, before we start, just to remind the audience to please use the chat box to post your questions and comments so that we can, at the end of each of the presentation, use this time to address some of the questions, but also the speakers will be also answering your questions via the chat. So without further ado, I would like to first introduce our first speaker today, is Louise KILLIN. Louise has been involved in clinical dementia research in Edinburgh since 2011. He has been also project manager for the Scottish Dementia Informatics Partnership and the Scottish Brain Health Register. Here, he reviewed the effectiveness of introducing new research methods and technology into clinics, as well as researching the national attitude to dementia research and the use of big healthcare data. He now works with the Neuroprogressive and Dementia Research Network under permission to contact scheme. So, Lewis, please, if you can share your screen, the floor is yours.
Okay, wonderful. Good afternoon, everybody. It's great to be here at this conference, and it's a real privilege to share our findings about the Scottish Brain Health Register and our experiences introducing it into a clinic in Edinburgh, Scotland. So before I get started, I just wanted to talk about some terms that I'm going to be using. Where I can avoid the term patient, I would prefer to avoid using it because I think it's a restrictive term. However, in this presentation, I do use it. And the reason for that is simply because we're talking about a memory clinic in the NHS, and we're talking about the perceptions and experiences of doctors and nurses as they would be talking about patients in their care. These aren't necessarily people who will go on to get a diagnosis of dementia. So I just wanted to say that where I've used this term in this presentation, it is with reason, and hopefully it will get a bit clearer as we go on. But the first thing I wanted to really ask is, why are we interested in integrating research into a clinical environment? There's 2 reasons, really. The first reason is that it's very, very difficult to recruit into research. And this has been quite a long-standing problem. And it's even harder to involve people living with a diagnosis of dementia. And this is for different reasons, one of which we'll focus in this talk. And another reason that we want to integrate these 2 things is that research can actually benefit people's standard of care. By taking part in the clinical trial, obviously people may have access to treatments that they wouldn't normally get through standard care. And also some of the assessments that happen in research protocols, things like more advanced neuropsychological testing or PET scanning. These are things that happen in research protocols and not necessarily as standard. So the whole benefit to people who are living with a diagnosis. So for a bit of context, I'm going to be talking about our experience in Edinburgh, and from 2 sides. My background is in research, and I'm going to be talking about the Scottish Brain Health Register, or SBHR. This is a research register that's been around for about 3 years or so, and it's open to absolutely anybody in the public. You don't necessarily need to have a diagnosis to take part, but the idea is that if you sign up to the register, you're essentially putting your name down to say, if there's a study that comes along and it's appropriate for me, I'd like to hear about it. And that's all it really does for the moment. It's managed through Edinburgh Dementia Prevention and is based at the University of Edinburgh. And then literally down the road, we have the clinic that we work with, which is called the Memory Assessment and Treatment Service, or MATS. And this is based in the centre of Edinburgh and will predominantly receive referrals from people's GPs. And these will be people who go to their GP and say, I've got a bit of difficulty with my memory and I'd like to have it checked out. So if they get referred to MATS, what would happen is they would see a team composed of nurses and consultants, psychiatrists, who would basically go through things like an initial assessment. they would have a consultation, possibly leading to a diagnosis if that's appropriate, and then things like post-diagnostic support and treatment evaluation afterwards. So the register has been in a clinic for about 3 years or so, and the work I'm going to talk about is essentially a bit of an MOT. It's a checkup to see whether this is actually doing the function that it should be. Is it offering people the opportunity to take part in research? And is there anything that we can do to improve it? Fundamental to all of this was our use of something called the theory of change methodology. I absolutely cannot do justice to this methodology in the time that I have, but what I will say is that this is a very important methodology that has helped us a lot, because it has asked us to really consider that as researchers or investigators, what we need to do if we want to affect change or introduce a new intervention is respect that reflects people's relationships, and it respects different relationships between different organizations, the motivations and attitudes of different people, and so on. So this has been a very, very strong methodology that's helped us. And that made us actually think about, well, what do we want to do? What are we actually trying to think about, and what do we want to see happen? And ultimately we came up with the idea that what we would like is, we would like to see an increase in the rate of people who are attending this clinic eventually ending up on the register. So we wanted it to be the case that for more people who are coming, having difficulty with their memory, that they would eventually be offered the opportunity to take part in research. And we wanted to do this in a way that was sensitive and to make use of current practice. So there are lots of different stages involved here. One of them was to do a bit of groundwork, a bit of fact finding at the beginning, to develop an intervention, understand whether we were being realistic with what we wanted to do, understand what it would look like if we were successful, actually make the change that we wanted to change, then have a review of it afterwards. And this was our timeline. So even though the register had been involved in the clinic for about 3 years or so, it wasn't until the start of last year that we actually started looking and reviewing it. Then it was in summer last year that we actually came up with an intervention. And then it was just around the time that lockdown happened in the UK that we had a reflection on what we had done to see whether we had made any kind of significant change. So before we did anything, we did a bit of research to see what were the attitudes about the register and what were the attitudes of staff in the clinic. We found that the register was playing an important part trying to integrate clinical practice and research. The nursing staff felt generally that research was a very important thing, and it was something that could be done as a collaboration between the NHS and university. The problem is that people tended to find out about the register kind of tangentially. They didn't understand it because they had been sat down and introduced to it formally. They kind of had heard about it and intuited what it meant. But because they didn't really have a formal introduction to it, it was very difficult for people to actually express what the point of the register was, or what benefit taking part in research could deliver to people's patients. So this was an important point. People weren't very confident talking about what was involved. The register, and by implication research, was seen as a bit of a black box, a bit of an unknown. And this was usually a conversation that took place with nurses and consultants and their patients at the point of diagnosis. A bit more background investigation showed that MATs would receive about 800 referrals a year. So that's 800 people turning up with difficulty with their memory. And a comparison of 4-month activity showed that the register was recruiting about 18% of the patient population onto the register. So these are people who would then go on to get a diagnosis of dementia or MCI. However, research wasn't offered to everybody. One thing that we found was that actually a sizable portion of people were labelled as not being appropriate or not interested. And that's the thread I'd like to pick up on later. On the other side of things, people who actually took part in the register said it was their first experience of taking part in research, and most people felt they were being approached at a time that was appropriate for them. So we took all of this information and we came up with an intervention which we discussed with the clinical team, and it's centered around better communication. So one of the first things that we did was we started monthly meetings between researchers and the clinical team to talk about what we were doing, why the register we felt was important, and why research was important. We also had training sessions for clinical staff. We had welcome packs, more information to explain what it was we were doing. We invited people to visit the site so that they could understand what it is we actually do and what it means to take part in the study. And we also wanted to give more examples of patient feedback. Now, by that, what I mean is if somebody was referred onto the register as they were seen in the clinic, they took part in the study, and then something good came from that, we would want to make sure that piece of good news came back to the same clinical team that referred them. We wanted that feedback loop to exist. And then changes in practice. Like I said, we wanted to be sensitive. We didn't want to be prescriptive and say, these are the changes we would like. So we came to an agreement of ways in which that we could help the clinic team. We identified research champions who could be the voices of research in the clinic. We wanted to move the conversation away from talking about research at diagnosis and more at initial assessment. We wanted to introduce a consent to contact form, and we also wanted to help out with some of the clinic responsibilities. In the end, we implemented 6 of these points, either fully or partially, and there were 3 points that we weren't able to deliver, and I'll talk about that later. So this was our outcome measure, patient consent rates. This graph shows the cumulative number of registrants onto the register. This is roughly where our intervention happened. And what we found is that we were basically seeing 23 new people per month through the clinic. The problem is that the majority of people didn't have a diagnosis. About 4 to 5 people per month who ended up on the register actually had a condition like a dementia or a mild cognitive impairment. So when we consider that as a very strict interpretation of what we were trying to change, our intervention didn't really make much difference here. So then we did a few more interviews to say, well, what happened and what could we think about? Although the staff felt that we had had a better introduction into the register, there was still this lack of confidence as to why people should take part in research and why the register was important. The important point here for me is that it was still not clear what way patients would actually benefit from taking part in research. One member of the nursing team put this quite finely, which is that if you've got a lot of things that you need to talk about in a short space of time, let's say in a post-diagnostic appointment, if you don't have an ironclad or confident or clear reason as to why someone should take part in a study, it sort of evaporates as a priority. It's not going to get to the top of your list when you've got other things to talk about like council tax, driving license, treatment evaluation. There are other things that take priority. One of the things we realized is that we were asking clinical staff to take too much of a research role, and that meant that we were overstepping some boundaries which we didn't appreciate. This came back to this idea that really there needed to be a researcher-based sessions with participants. So the implications then, we found that there was a bit of an issue with clarifying the ways in which people benefit from research. In our interviews, we found out that people were prescribed to the idea of the greater good. Research is something that helps people and it is a benefit to society. But to understand exactly how somebody could benefit from taking part in a study at that point in time for them as an individual was difficult. And that's a point of reflection going forward. A few other points that I wanted to highlight is that although we found it very easy to set up clear channels of communication between researchers and clinicians, that's not to say that it's not important. I would say this was a vital part of our intervention and hopefully something that will carry on. And again, this idea of having a permanent researcher based in the clinic seems to be an important consideration going forward. One thing as well is that this obviously reflects a register that's been in a clinic for 3 years. Our intervention was only for a few months. We're not seeing this as a sprint to achieve a very fragile goal. We see this as a marathon, and we see this as something that's going to take time, a lot of conversation, discussion, and really working together to actually improve the ways in which people can get the opportunity to take part in research. Finally, limitations. We were talking to members of staff of a service. We didn't get a lot of insight from the actual consultants who work in the service. Similarly, because we were looking at the service, we didn't have a lot of insight from the people attending, so people who may have had a diagnosis. And we are looking at this in other lines of work, but for this particular project, we didn't have a lot of feedback from people living with a diagnosis or going through the service. It's very specific to Edinburgh and the way that Edinburgh does things. It's not necessarily reflective of Scotland or even the rest of the UK. A consideration with COVID, which is completely unavoidable, we find that asking somebody to be based in a clinic at the time of COVID seems like quite a bad idea. More people in a small space isn't the first thing we should be doing. But since things are migrating to being online and the use of things like video conferencing, that sort of thing, there seems to be a nice opportunity for researchers to be involved as part of the consultation or assessment that way. And my final point is the types of research that we offer. So I've been quite careful not to mention specific types of dementia or specific types of research, but I will say that we are biased towards a particular type of dementia and a particular type of research. If we had a wider portfolio of studies that would be of benefit to people with less common types of dementia or different types of research that don't seem obvious to us but are important to people living with those conditions, then that seems to be a good place to start when we think about ways in which we could be helping people. And this is actually my final point, sorry. I want to say thank you to everybody at the university and NHS Lothian who worked with me on this. This is not a funded project. This is something that we did sort of in addition to our roles. And I think that stands as a testament to the fact that we think this is important. It's worth working on, and it's worth doing this as a long-term project to make sure that together we can come up with something that is of benefit to people who are concerned about their memory. Thank you.
Thank you so much, Luis. It was a very good presentation, very interesting work in the register and the intervention. I don't see any questions in the chat right now, but I just wanted to ask you a very quick question, and is when you were talking about communication, mainly within the clinicians and the researchers, and also to try to bring the voice of people involved, of the patients. I was wondering about the general public. Do you have any action beyond the clinic and the register? Do you target the general public about this work, or how are you looking into that?
So we've been really lucky that we've been able to do a series of surveys online through Help with Alzheimer Scotland, where we asked the general public what were their priorities and attitudes towards dementia research. There's lots of different pieces of the puzzle. So obviously you have the situation as it is in the clinic, and then you have the situation as it is in the general public, and then people who are concerned about their memory. And what we've been able to do is do different bits of work in isolation to draw it together and say what is important to people in the clinic is actually the same as what's important to the general public. So the survey work, which we're working on getting published at the moment, does show that people are very interested in things like early detection. They're very interested in support and research that could be a benefit to carers. As researchers, that then tells us that we should be thinking about what sort of protocols we could be developing, we could be offering to people, and things where there's kind of a need or an ask for us to be researching that. So like I say, it's going to be a long piece of work, but we're gathering bits of evidence as we go.
Excellent work, Lewis. Thank you very much. The next speaker is Karen RENNIE. She's going to be talking about sexual expression in persons living with dementia and impact on person-centered nursing in a care home setting. Karen qualified as a nurse in 2017 with a first-class honor degree, and now is a PhD candidate and research assistant at Queen Margaret University within the Centre for Person-Centered Practice Research. She is also working clinically as a registered nurse in a nursing home in Edinburgh, the UK. Her PhD is exploring the lived experience of sexual expression in persons living with dementia who are living in a nursing home, and she is also exploring how nurses experience the sexual expression when caring for people living with dementia. She has a strong interest in participatory research approaches and into ensuring that persons living with dementia have a central voice within any research that is done about them. So Karen, the floor is yours.
Thank you very much, Anna, and hello out to everyone from all over Europe and all over the world, and thank you for coming to listen to this presentation. My name's Karen, and I'm going to talk to you about my PhD research, which is due to finish. I'm due to submit my PhD just before Christmas, so I'm very much at the end. So this is my first presentation sharing the findings with the wider world. So I'm going to provide an overview of my PhD and discuss the key findings. I'm also wanting to present to you a new conceptual framework that has emerged through my PhD studies, and which is called the sensuous framework, and discuss the relationship between sexual expression and the sensuous framework, And I also want to just highlight the implications for practice, research and education with this study. So just to give a bit of background, the literature behind this topic is very weak and sparse. There isn't a lot of work done on sexual expression in people with dementia, and much of the work that has been done came from the healthcare perspective, professionals' point of view, and not the people living with dementia themselves. Sexuality and sexual activity remains an important part to people's lives as they grow older and also as they develop dementia. However, there's a problem with nurses find it a problem to discuss this, and also sexual expression can be represented in ways that we consider inappropriate. And much of the literature and care models around sexual expression comes from the behavioural and psychological symptom of dementia paradigm, which I want to discuss in a bit more depth with you. So my research explores what is the meaning of sexual expression in persons living with dementia who live in a nursing home setting, and how is sexual expression understood by the nurses. So I wanted to gain understanding from both groups of participants, from people with dementia themselves, which this has been the first time in the UK and in Europe, as far as I'm aware, that people with dementia have been included in research surrounding sexual expression. I also want to, the aims of the study was to explore how it's understood by the nurses and how it impacts on the person-centred care that they give, and then to explore the relationship between my framework, sensuousness and sexual expression. So my research stems from a person-centred worldview, and in person-centred research, it is really important to understand the philosophical underpinnings and your ontological view of what is a person and personhood. So I spent a good year of my PhD immersed in philosophy, and really grew connections with philosophers such as Maurice Merleau-Ponty and Mark Johnson, who claim that persons are embodied being in this world, and our perception, emotions, senses and desires are crucial to human existence. And also our emotions, senses and desires are part of how we create meaning in this world, and our cognition abilities build on that. However, in Western academic literature and research, these aspects of being are usually forgotten, and we pay so much more attention to the cognitive parts of being human that then therefore people with dementia can fall short of, and therefore their understanding of personhood it clashes with this view. So I found that this understanding of personhood was far more suited me, and then really related to people living with dementia. So if I go on to the behavioural and psychological symptoms of dementia model, this is the model that dominates Western healthcare just now, and this is the model that claims that sexual expression is a symptom of dementia, and that therefore suggesting that it's unnatural and negative and very problematic, rather than the viewpoint of, you know, sexuality is part of who we are as human beings, and that it connects us with our emotions and desires. And therefore, if someone with dementia expresses themselves in a sexual way, it gets viewed as a symptom and an indication of their illness, rather than part of who they are as a person. And this was something I really wanted to challenge within my research. And as you can probably see from my last slide, this model really, there's a real disconnection, and I couldn't find another theoretical model that fitted with my values and beliefs as a nurse and as a person-centered researcher. So I decided to create my own, and this is my sensuousness framework. And what I have done is redefine the word sensuous and sensuousness. So the way I'm defining sensuous is our ability to have bodily experience through our emotions, senses and desires, and they lie core at our personhood, and we experience them through our feelings and sensations and pleasures respectively. And therefore sensuousness, which is on this outer layer of this circle, is the gratification or expression of those deep emotions, senses and desires. And the reason that I have put this into circles like a layer and layers is because for me, what happens with people with dementia is that they express what they're feeling and seeing. However, people from the outside, such as nurses, healthcare professionals, the general public, see the expression without understanding the emotion and desires and senses which lie deep within them. And we struggle to understand where it's coming from. Therefore, we see it as a behaviour rather than part of who they are as a person. So what this definition of sensuous achieves is that it incorporates all our emotions, senses and desires and how our bodies react to those feelings. And this is how I position sexual expression, and therefore it's part of personhood, and therefore what we are seeing as part of who they are as a human being. And it's their general communication and a way of expressing those emotions and desires. And by viewing sexual expression through the lens of sensuousness, it highlights that, you know, one gesture or movement can have very multiple meanings depending on the person and can be very context bound. But traditionally, it's nurses and healthcare professionals who assume they know what that expression means, or that they believe that it's dementia that's causing such an expression. So that's my theoretical background, and I'm happy to take questions at the end because I appreciate that I probably gave a really fast track view of that. And so when I looked at my methodology from my research, because I had a different philosophical and theoretical background, I couldn't find an exact methodology that would fit with my research. I was drawn to existential phenomenology a lot, but there was something for me missing, and that was the importance of our senses, emotions and desires, our thoughts, feelings and sensations as well. So I created my own sensuous methodology, which incorporates principles from existential phenomenology, sensuousness, which I've just described to you, and also person-centered and participatory principles. So for example, giving participants as much of a choice as possible and giving them free choice and letting them make their own decisions how much they want to be involved in this research, should they do so, and really creating that therapeutic participant and researcher relationship. So my research was taking place in one nursing home in Scotland, and I had 11 members of the nursing team and 4 persons living with dementia, and these are all their pseudonyms that I gave them. And unfortunately, I was hopeful, I did recruit some more people living with dementia living in the nursing home, but lockdown in the UK happened, so I wasn't able to include them into research, but I'm hoping at some point in the future I can offer them to be included in future research. So the participants were included in the research as far as possible and given free choice, and it was done on a volunteer basis. So no one was, I didn't approach anyone, and they came to me if they wanted to be included. I worked in the nursing home alongside doing the research and spent two to 3 weeks being there as a honorary staff member to allow myself to get to know the people working there and living there. And to build, as this is can be such a sensitive topic, I made sure that I spent time with every participant before I started collecting data, so that they could ask me any questions. They got to feel more comfortable with me as part of the research as well. And For people living with dementia, this is the first research that has included people living with dementia who are classified in Scotland as an adult with incapacity, therefore unable to give informed consent, or viewed as unable to give informed consent. So a research plan was created with the residents living with dementia, and an option was to include the families as well. However, interestingly, no family members opted to be part of this process. They all wanted to give the full responsibility to their loved one with dementia, and the people living with dementia all chose not to have a family member to have this conversation with me. So capturing the experiences of sexual expression was a very interesting process, and I had conversational interviews with both people living with dementia and the nursing team. Conversational interviews meant that I had no interview schedule. We had cups of tea together and we let the conversation go. I did have a rough topic guide in case we didn't end up talking about sexual expression at all. However, those topic guides got shared with the participants before, and it was them who brought up the topic of the conversation rather than me guide them. So they took the lead in the conversations. I also done participant observation with the nursing team only, and I did not because there was too many complications with ethics to include people with dementia with that, and that gave me some information on how the nurses interacted with the people living with dementia, and gave me a broader understanding and context of the nursing home. Radical reflection and reflexivity was really important to me. So rather than come from a point of view that I tried to remove myself from the data, I reflected on a daily basis to understand what my own assumptions, what I was understanding throughout the day, which helped me separate what I was understanding and what the participants were saying as well. And I went through a process of existential analysis and to discover the essences and the hidden meanings of sexual expression. And I kept the two participant groups separate. So for the nurses, sexual expression was a real challenge and uncomfortable phenomena for them. And it ranged from a various spectrum, various expressions, and with some being seen as acceptable. For example, holding hands was okay. However, anything further than that, whether that was kissing and cuddling or even masturbating, was deemed unacceptable. And there was also a dynamic spectrum of the issue with privacy came up as well. What was really interesting, the nurses did consider sexual expression really important to a human desire, however, did not associate it with older persons living with dementia. And it was more of rather than the cognitive issues that people with dementia have, it was more of the older ageist assumptions that they were making regarding people with dementia. There was also desexualization of the body. So they saw the body as a very clinical object. In fact, that they've got to provide personal care, keep them clean and things, rather than seeing them as sexual beings. They made no attempt to find out what any of expressions meant to the person, and they would quickly try to ignore it, distract the person, or have to report it. Or sometimes actually approaching it with humour was very common for the nurses. The essence of sexual expression for persons living with dementia was very interesting, and I had such heartwarming conversations with them. They all considered aspects of sexual expression really important to them, and was one of the most missed aspects of living in a nursing home compared to the private home. All of the participants spoke about the desire to be physically close to another human being and for that intimate contact and sexual touch. They also discussed that as they grew older, they experience more pleasurable sensation and that their body becomes more sensitive. Therefore, when they feel pain, they feel it worse, but also when they feel pleasure, that it becomes stronger as they grow older. Sexual expression made them feel loved, special, and provided them with happiness. It was also about reminiscing about meaningful relationships, both past and present. Some of the participants were widows, and therefore they reflected a lot about their previous relationships, and some were reflecting on their own current relationship with their partner living in their private home. They all connected their sexuality with either their femininity or masculinity, and they all thanked me very much for having a conversation and really enjoyed speaking about their sexual expression as well. But they do feel like there's insufficient time, space, and privacy in a nursing home environment to express themselves. And one of the quotes that really stuck out to me was someone said that they just knew that that part of their life was going to be forgotten about and ended with moving into a nursing home. So through those essences of sexual expression, I created 4 rich definitions that describe the phenomena of sexual expression in people living with dementia and the lived experience. And I also spoke about the nursing team's experiences of sexual expression and their lived experience of caring for people living with dementia. And you'll see on the screen here that the 4 definitions could not be any more different in terms of, one, the people with dementia is very positive and joyful and heartwarming, whereas the nursing teams, it's quite challenging and negative. And this showed to me how both participant groups are quite poles apart when it comes to this sexual expression. So the nursing team, to look deeper,
Sorry, you reached your 15 minutes. If you don't mind, 1-2 minutes more.
No problem.
Sorry
No
about
problem.
that.
So you can see here that much of the nursing team's perception came from their own values and beliefs about older person's sexuality and cultural norms around the aging body and people with dementia and sexuality. For the people with dementia, it was about their meaningful relationships and their own feelings and desires. And just to conclude here, this has been just a wee stepping stone in addressing this phenomena and this topic. There's so much more work to done to bring those 2 participant groups together so that they're harmonizing rather than in unison rather than being poles apart. So there's so much more implications for practice, and there needs to be embraced this new understanding of sexual expression that embraces these emotions, desires, and senses. And there's further research to include people with dementia who are seen as adults with incapacity, and further research for nurses and healthcare professionals. So I'd just like to stop there and thank you very much.
Sorry, thanks a lot, Karen, for a very interesting presentation. I think it's a fascinating topic. I just echo some of the comments on the chat, saying that thank you so much for calling out this very outdated framework and finding a new way of framing sexuality. So good luck with your PhD submission. I'm sure it will be a very nice publications out of this PhD. And I'd like now to introduce our next speaker, is Fiona KEOGH. She's going to speak about innovative methods for involving people with dementia and cares in the policy-making process. Fiona is a senior research fellow in the Centre for Economic and Social Research in Dementia in the National University of Ireland in Galway. She has over 20 years experience in developing national policy and conducting health service research in Ireland in the areas of dementia, mental health and disability. Throughout her career, she has worked directly with people using health services in research and policy development. So the video, please.
Hello, my name is Fiona KEOGH and I work in the National University of Ireland in Galway. And I'm delighted to be taking part in this online conference today. Of course, I'd much rather be meeting you all in person, but I think this is the next best thing. So today I'm going to talk about the use of public and patient involvement in the policymaking process, or PPI for short. Now, many of you have probably heard about the use of PPI in research, but I'm going to broaden the scope of that understanding of PPI and talk about PPI in policymaking. I'm going to draw on some examples from work that I've done in the University in Galway in partnership with the Alzheimer Society of Ireland and the Irish Dementia Working Group and others. Now, policy is a word that we use a lot, but we may not be really clear on what it is or how it's made. So simply put, a policy is a set of ideas or plans that's used as part of the decision-making process, usually in politics or business or economics, or today I'm going to talk about health policy. So for example, Ireland's national health policy on dementia is to support people with dementia to remain living at home as well as possible, for as long as possible. And health policy in Ireland is made by the Department of Health. And they do that in consultation and by bringing together a lot of other stakeholders. Now, PPI in the policy-making process is important for a number of reasons. It brings together a diversity of voices and perspectives to the policy-making process. And in that way, it democratizes policy-making. It uses and values different types of expertise, and by including people with lived experience and carers and so on, it really brings, values that type of expertise as well in policymaking. And it leads, hopefully, to policy that is much more directly relevant to the people who are using health services, as well as to the people who are delivering those services. Now, I'm going to use this framework today to structure what I'm talking about. And these are the stages of the policy cycle, beginning with agenda setting, exploring policy options, leading to decision-making about policy, and then implementing that policy and evaluating that policy in a cycle. Of course, this looks very organized and linear, but in reality, policy-making is much messier. So things are often happening in parallel. There's a lot of going back and revisiting ideas and so on. But for the purposes of this presentation, I'm going to stick to this kind of very simplified and organized model. And I'm going to talk about two initiatives that we undertook with people with dementia and carers. The first is a policy cafe, and the second is a carers assembly. And we used both of these. These are both relevant to agenda setting in the policy cycle. So what are the issues that really matter in terms of policy, and what do we want to see developments of in terms of policy, and then exploration of the policy options. So what should our options look like? So I'm going to describe those two things for you now. The first is the policy cafe. So the policy cafe took place with 10 people with dementia, and the idea was to have conversations on two issues, home care and diagnosis, with a particular focus on policy and policy orientation. Now, the cafe was very much co-produced, and that means that people with dementia were involved in selecting the two topics and in the format and so on in organisation. We used different media to really help capture the outputs. So as well as just taking notes, which is very useful, we wanted to make it very accessible. So with the permission of everybody there, we filmed the proceedings of the day, and I'm going to show you a clip of that in a minute. And we also had an artist there doing animation in real time. So the emphasis was on an event that was informal and relaxed and fun, but very much with a serious focus on impacting policy for dementia. And we used the World Cafe methodology, which some of you may be familiar with. We adapted that to run this policy cafe. And this is an example of some of the illustrations that the artist produced. And the participants found it really useful to be able to look at those as the day was going on, as the discussions were going on. And it really helped to see their own ideas in a kind of a visual format. The priorities that were identified for home care are listed here. I won't talk through them all, but things like the model of home care was very important, the pathway, training and support for carers, adaptation, housing, and of course funding and rights. The priorities identified in relation to diagnosis were the importance of awareness that diagnosis should be personalised to each individual, proactively linking people and providing supports, a timely diagnosis, and a right to know a diagnosis. I'm going to just share now with you a clip from the Policy Cafe, and just bear with me while I find that and play it for you now.
I think it's a brilliant idea. What I love about it is the fact that it's people with dementia are being listened to. And that's taken a long, long time. We have the people that know, we're the experts. So when we're here today and we're able to put down what we think we need, what we know we need, what we think our carers will need, it's very, very important to have our voice heard.
Went from maybe something's wrong to give up your work, give up your job, yes, give up life, you know. And now I'm fighting back now. But this isn't an illness that is predominantly old people anymore, and so we need to speak up and say that we need help from policy, we need help from government, and we need help to have something that goes right across our country.
For me, a big thing within that, and I don't know how it comes under there, Fiona, is the fact that if you live rurally and you're driving,
yes,
it's life-changing. It throws into question everything you thought would be, you know, down the road. It was hard being on my own two guides. But we all bring our own dynamic to this disease and our own way of dealing with things. And so for me, it would have been very much, what can I do about this? What can I learn about this? It's in our home. It's nearly taken out of the hospital and the doctor's surgery at that stage. It's like,
Now I'm going to go back to sharing my presentation. Okay. There's a longer film there, and I have a clip, the link to the film at the end, but I hope that gives you a flavour of what we did on the day. So the Carers Assembly then was a forum to hear the views of 30 family carers of people with dementia in relation to dementia care in Ireland. And we modelled that on the Citizens Assembly, which had been run in Ireland a number of years ago. So that involved presentations on specific topics that were discussed by carers, and then there was a ballot. They developed a ballot to vote on the issues and to rank them. And carers were involved in deciding what would be discussed on the day and what would be included on the ballot papers. And this is an example of the ballot paper on the elements that would be considered part of quality home care. And you can see the important issues there that were identified prior to the assembly in black. And then the two in red were actually added on the day as part of the discussions, as a result of the discussions. And again, we had the animator, the illustrator there to capture the proceedings in a very accessible way. And we also filmed the day, but I don't have time to show you a clip of that in the presentation. So other ways in which people are involved, people with dementia are involved in the policy cycle, is around policy implementation. I'm going to give you 2 examples briefly of advisory committees and oversight groups. And this isn't work that's directed by the University in Galway, but I wanted to give you some examples as to how that can happen. So the National Dementia Strategy in Ireland has a monitoring group to oversee the implementation of the strategy. And there's a person with dementia, a family carer, and the National Advocacy Organisation and the Alzheimer Society are all members of that group. So they're involved in the oversight of the implementation of policy. And people with dementia are also members of a number of advisory groups established by the National Dementia Office to oversee the implementation of various actions within the National Dementia Strategy. So it's very much become embedded in how things are done here in Ireland, which is very, very heartening to see. I'm just going to pull together now what we've learned about involving people in the policy making process. So to do it well, it takes time, especially when you're working with people with additional needs and people who may need support with cognition and communication and so on. So it's really important to build relationships, and that takes time, but it's well worth it. And you can get really good relationships and long-lasting friendships out of that. It also is worth investing time to prepare and giving the people who are going to be involved lots of opportunity to input into that and to comment. And it's important to pay attention to the details because it's the little things that really matter on the day in terms of whether people have a good experience or not. We found it really helpful to tailor our support to the different needs of each of the participants, each of the PPI contributors, as each of them have different needs in relation to communication and their skills and abilities at any one time. It's really important to respect and balance all of the expertise around the table. So individuals have their own priorities based on their experiences, which are really important to hear, but we need to keep in mind they're not necessarily representative of everybody's experience. It can be a challenge to distill out the messages that have wider relevance, but principles of validity and rigor really remain important in that process. We have found it really helpful to be creative and open. So we use different approaches to get the best out of everyone. And we use different media to communicate, as you can see, through film and illustration. And finally, we have tried to bring all of that learning together into a set of guidelines, and we co-produced a toolkit with the Irish Dementia Working Group and the Alzheimer Society of Ireland. And that includes detailed best practice guidance on involving people with dementia in consultations, meetings, policy development and conferences, and you can find it at this website. I really want to acknowledge the collaborations and partnerships that we have and everybody who participated and the funding that we received from the Health Research Board. Thank you very much.
Thank you so much, Karen, for this very interesting presentation. I see in the chat already a few comments just to say there was a fantastic idea to involve the artists in this work, which I think was really, really interesting, but also some of the people who are involved. I think Kevin is also part of the audience, and he was reiterating that how important that policies cafes are and how much people are gaining from it. So thank you so much for the presentation, but also for this fantastic work you're doing in Ireland. And I'm pretty sure there will be more questions for you, Fiona, in the chat box. Thank you very much. I'd like to introduce our next speaker, also from Ireland. This is Cathal Blake. He will be speaking about using public transport, the experiences of people with dementia. Cathal worked in construction for 26 years and returned to education as a mature student in 2015, age 42, to study psychology in Dublin City University. During his degree, he became interested in neurodegenerative diseases with a particular interest in young onset dementia. And his final year thesis examined caregivers' experience of young onset dementia in Ireland. After this, he's now doing his PhD. He's in his second year, and he's continuing on the same topic. And he's also a tutor on different modules at DCU. Cathal, I think it's also a pre-recorded video. So if we could see the video, please.
Hello, everybody. I hope everybody's keeping safe and well during these strange times, and hopefully we'll all see each other soon. My name is Cathal Blake. I'm a PhD student in the School of Psychology in Dublin City University in Ireland. My research supervisor is Dr. Louise Hopper, and my presentation is titled Using Public Transport, the Experiences of People with Dementia. First of all, I'd like to make a few acknowledgements. I'd particularly like to thank the participants and their family for their time and dedication during this project. I'd also like to thank members of the Alzheimer Society of Ireland, in particular Dr. Bernadette Rock, Dr. Laura O'Philbin and Claudia Whelan for all their assistance. I'd also like to thank Cathy Ryan from the Irish Dementia Working Group for her help, and also my supervisor, Dr. Louise Hopper. This research was conducted last year in 2019, pre-COVID. The Irish Dementia Working Group were set up in 2013, and they have since grown in size and numbers. At one of their meetings, it was decided to investigate the topic of people living with dementia and their use of public transport. As a result of this, the Alzheimer Society of Ireland came on board, and they funded and commissioned this research. The specific objectives were to review the literature in relation to the issue of public transport and access for people with dementia, to conduct a qualitative analysis of the experiences of people with dementia have when using public transport, and to collate the findings and recommendations into a report. Public patient involvement was used in this research. PPI can be defined as research being carried out with or by members of the public rather than to, about or for them. PPI also allows public and patients to be involved at every stage of the research, from initial inception to final dissemination of results. The LIT review was utilised to identify existing literature in the area of dementia and public transport across all elements of the travel chain. The literature search was carried out using a wide range of databases accessible through Web of Science, psych articles and psych info. Grey literature such as government reports or position papers were also included. To be eligible for inclusion, the articles had to be written in English, published in peer-reviewed medical and health, technical or social science journals, and address the areas of cognitive impairments in relation to the use of public transport. Search terms used included cognitive impairment or dementia, and driving cessation or public transport. An overview of the computerized search process and disciplines used are presented in figures 1 and 2. Figure 1 here shows the literature review, where the initial search yielded 345 results, and after abstract review and full text review, the final selection included 56 articles. Also included were 9 articles of grey literature. Disciplines used in the LIT review range from psychology through gerontology, geriatrics, and psychiatry. So findings from the LIT review outlined that many people with cognitive impairments may anticipate difficulties when using public transport, even before they leave the house. For example, research conducted in Sweden by Abslund and colleagues in 2012 surveyed over 800 people post-stroke, showed that the majority had not utilised public transport after their stroke. Research by Wendell and colleagues in 2010 similarly found that up to 1/3 of individuals living with some form of cognitive impairment reported a significant decrease or no usage at all of public transport compared to pre-impairment. This sense of anticipation may stem from a decreased level of self-confidence, resulting in a reduction of public transport use. People living with dementia may choose a variety of different ways to access activities outside the home, such as walking, cycling, using various forms of public transport, buses, taxis, trams or trains, or indeed they may even drive. However, driving requires a particular set of skills that may be adversely affected by cognitive impairments associated with the diagnosis of dementia. Public transport therefore may allow for autonomous outdoor mobility for individuals who can no longer utilise a motor vehicle, which may help to reduce an individual's reliance on support of family, friends and or social services, and help them to remain actively engaged in their own community. As social participation is increasingly used as an indicator of health and well-being, the use of public transport may become the only link to continued societal participation and a sense of independence. To achieve the study aims, a qualitative research design was used combining pertinent literature relating to dementia, driving and the accessibility of public transport, combined with diary, field notes and interview data. Participants were people living with a diagnosis of dementia, who were members of the Irish Dementia Working Group or who were affiliated with the group, or the Alzheimer Society of Ireland. Travel companions, for example, a spouse, partner, family, friend or carer, also participated, where they have supported the person with dementia to plan or make their journeys. The sample size, although small, is consistent with similar research in this area. Table 1 includes an overview of participant characteristics. We had 5 participants, 1 female and 4 male. Some still drive, some don't drive any longer. They're resident all over Ireland, some in rural areas, some semi-rural and some urban. Ages range from 56 to 80. They were diagnosed with various subtypes of dementia, and they all use various forms of public transport frequently. Materials that I used during the evaluation were audio recording equipment and notebooks, and then the procedure allowed participants to take 1 or more journey on public transport and record their experiences of both planning and taking those journeys. For example, participants may have elected to record a specific journey, i.e. a special trip or going on holidays, or a standard typical journey that they make frequently, or a combination of both. When a journey was made frequently, participants were encouraged to record their experience more than once. Participants undertook their journeys in their normal fashion, so if they typically travel alone, they did so in this case, and if they typically travelled with someone else, the same process was followed there. They recorded their experience of making their journey either on a dictaphone or some sort of voice recording, for example, a phone, or a written diary or field notes, or via an interview with myself following the journey. The participants themselves selected the most comfortable method for themselves. When a participant selected an audio or written diary, they were made aware that I may wish to conduct a short interview just to clarify some details. Interview data were analysed applying an inductive qualitative thematic analysis that used open coding and derived categories directly from the interview material. The reason why I wanted to look across all the travel chain is that using public transport is not a simple procedure. It involves several factors across the whole chain. For example, the pre-trip planning and pricing, the booking or ticketing, getting to the transport hub, checking in and boarding, on the journey itself, and then the destination or post-trip. Findings from the interview narratives included both dementia-specific factors and environmental factors that can act as both barriers and facilitators to public transport use. Dementia-specific factors included stigma, stage of the condition or level of impairment, sense of autonomy, sense of unease or discomfort, while environmental factors included the physical environment, the rural-urban divide, the accessibility and availability of transport, and greater public awareness. Dementia-specific factors and some quotes to outline taken from the narratives. Yes, there's people that have dementia that don't want anyone to know, and it's a bastard for them. That's solely because of the stigma that goes with it. I can read the timetable. I can work on that. I haven't reached that stage yet. When I was first diagnosed, I would never take the train on my own. My wife had to go everywhere with me. But once I got used to it, the staff were more than willing to help. All you have to do is ask them. I have taken the train and sometimes I have to stand. The bus is always crowded. I feel awkward. It's difficult for vulnerable people to use busy transportation. And some quotes to outline the environmental factors. There was a big crowd getting off, and I didn't see the railings or the gate. I was pushed through the gate, missed the curb and fell onto the road. We live out in the country and our nearest town is 3 miles away. If I had to get a bus in the morning, I would have to get a lift 3 miles into town. There's no link service into town whatsoever. It had been a long week. I was pretty exhausted getting the train and I had to do this bit totally on my own. A lot of people got off the train and everyone seemed to be in a hurry. The staff know me now. They know I have dementia and they're absolutely wonderful. In conclusion then, this study provides an insight into the experiences of using public transport for people with dementia. Findings shed light on both personal and environmental factors that act as either barriers or facilitators to public transport use across all elements of the travel chain. These findings demonstrate that public transport, when and where available, can be used by people with dementia to actively engage in their society. Many individuals with dementia do not require any assistance to navigate the various public transport systems, mainly due to the stage or severity of the condition. In other words, People who are living with a relatively mild cognitive impairment appear more able when accessing public transport. However, for many more individuals with a significant impairment, they do require assistance. Because of the hidden nature of dementia and the lack of public understanding or awareness can act as a barrier for these individuals. Some recommendations from this research: public transport staff and the general public could benefit greatly from training or education programs, specifically focused on recognizing the signs and understanding the effects of cognitive impairment in order to increase their knowledge about dementia. Training may reduce the stigma and allow public transport staff to facilitate people with cognitive impairments, such as dementia, thus making public transport hubs more dementia friendly. The anxiety that people with dementia may feel about using public transport may be reduced if public transport staff are dementia aware. However, this must be a bi-directional relationship between people with dementia and public transport staff in order to share knowledge in relation to the condition and to facilitate greater dementia awareness. People with dementia should be involved at every stage of any training or education programs that public transport service providers may undertake. This in turn may allow people with cognitive impairment such as dementia to disclose their condition without fear of being stigmatized. That wraps up my presentation. Thank you all so much for listening, and hopefully we'll see each other soon.
Thank you so much, Cathal, for this very important work for the everyday life of people with dementia. Unfortunately, we are running really late, so I'm going to introduce our last but not least, but very important speaker too, Hildegard SCHMITT. Hildegard works as a graduate psychologist for the Association Luxembourg Alzheimer. Since 2017, she has accompanied the first support self-help group for people with early stages of dementia in Luxembourg. And if we can see now her video, please.
Welcome to my presentation. I want to talk about our experiences with the first supported self-help group for people with early stage dementia in Luxembourg. After giving a short introduction and background information, I will raise 3 questions and tell you about the results and consequences of the corona pandemic before drawing a conclusion. In 2017, the first supported self-help group for people with early stage dementia in Luxembourg was established by the Association Luxembourg Alzheimer, ALA, financially supported by the Ministry of Family Affairs. In 2018, the concept was evaluated by the means of qualitative interviews. And since 2018, we are going on implementing the results of our interviews. To analyze the situation of people in early stage of dementia, first we had to consider some general aspects. When confronted with the diagnosis for the first time, a range of different emotion appears. Shock, anger, anxiety, the feeling of being lost, sadness, frustration, and shame. There are thoughts like, how will it go on with my family, in my job, and often horrible pictures from old and suffering people who need a lot of care appear in their minds. It cuts the ground from under their feet. In Luxembourg, the prevalence rate of dementia does not differ from that in other Western European countries. We also have good consulting and care services for people in the later stages of dementia and for their relatives. But what about people who are confronted with a diagnosis for the first time? In addition, we had to consider the specific situation in Luxembourg. Luxembourg is an immigration country with about 48% of the population with foreign nationality. We have a high variety in cultural backgrounds and spoken languages. Luxembourg has about 600,000 inhabitants. That means that everybody knows everybody. As a result, the inhibitory threshold to seek support is even higher than it is due to the symptoms anyway. The concern that the protected frame, the privacy, is not guaranteed is huge. So the following questions were raised. And the first question concerns the process of support. How can we reach people in an early stage of dementia? How can we accompany them for a while in their individual process within the group? And how can we find a good transition from the group to more appropriate structures with the progressive dementia? More and more people find us on our website, but the first contact is usually made through our social and coordination service or through the staff of our outpatient support service, ALA Plus. Even before starting with the participation in the group, we try to build confidence by individual talks with the people concerned to get to know each other. Expectations and fears can be discussed, as well as any other concerns. How do we accompany the process? We build a secure framework, for instance, by implementing inclusion and exclusion criteria. We work need-oriented. That means we do not determine the contents of the group sessions in advance. The participants themselves determine what to talk about. We work resource-oriented and we work target-oriented. For instance, by encouraging participants to perceive their own needs, to articulate them in order to be able to live them. We offer accompanying one-to-one interviews with the affected people and their closest relatives. As soon as we realize that the group becomes an overload for a group member, this is discussed with the participant and alternatives are offered to him. That may, for example, be a smooth transition to one of our daycare services or any other structures of the ALA. The second question concerns the paradigm shift. How can we establish the idea people with dementia are the experts of their own life into the thinking and acting of professionals, the people concerned, their relatives, and a broader population? We can achieve this by providing them with a protected and trusting framework. We encourage them to speak about their thoughts, their feelings, and their needs. They can practice this in the supported context of the group before going more and more to the public in small steps. For every step we do, the feeling of being protected has to be guaranteed. It seems to be very important not only to speak about autonomy and independence, but, and this also challenges the professional caregivers, to bring it into our daily life while accompanying people with dementia. And third, we consider the quality. How will we record the quality of our offer and implement the results? After 1.5 years as a pure discussion group, the group was evaluated by qualitative interviews with the group members and their relatives. Talking about the results of these interviews, first of all, I would like to quote some of the participants. There is no "you have to" here. Everybody respects everybody just as he or she is. I don't have to be ashamed. The exchange with people in a similar situation is good for me and encourages me. I know I'm not alone. We learn from each other and we laugh a lot together. People recognize who I am and not what I have lost. By and large, the group concept was maintained. However, there was one fundamentally important change. The group participants did not want to work only as a pure discussion group, but additionally wanted to have joint activities. Therefore, our concept has been adapted and the following group activities have been carried out to this day. They visited former group members who had changed residence or institution. They visited a cinema. They had an exchange with the ALA employees. They participated in the quality circle of the ALA. They wrote a newspaper article. They participated in developing the Dementia language guide by German-speaking Alzheimer's and dementia organizations, and they participated in a research project of the University of Luxembourg. Since the planning and implementation of activities also require higher personal capacity, the adaptation of the concept must be coordinated with the ministry. This is on its way. The consequences of the corona pandemic and a short preview. No group meetings were held from February to June 2020. The contact to the participants was held by phone. Video conferencing was not possible because several participants are not able to cope with this medium. Since July, we have met again under the given safety precautions. However, most of the planned activities are still not possible, so we looked for alternatives. For instance, one woman brought her self-sewed clothes and presented them to the group. Next month, the group is going to visit another woman who worked as a painter and will see her works in her studio. In December, we are planning to conclude the year in a relaxed atmosphere and have invited our director to an informal exchange. The group will no longer function as a pure discussion group. We will plan activities as possible under the actual circumstances. We will keep on supporting the participants to find their own way of coping with the dementia, and we will continue to support them to develop a new life perspective. To sum it up, only when we enter into dialogue with people with dementia, when we hear what they have to say, and when we take that, what we have heard, seriously, and only when they receive support on their way, people with dementia have the chance to be seen as the experts of their own experiences and their own situation. The last word should be given to one of the participants. With the support of this group, I found the courage and strength to face the challenge of this disease. Thank you for your attention, and for further questions, you're welcome.
Thank you so much, Hildegard, for your very nice presentation. I just want to echo some of the comments in the chat saying how important what you said about recognizing people with dementia as experts on living with the condition, and what a powerful and important statement that was. So thank you so much. I think we unfortunately have reached our time. I hope we had still now another hour for discussions, because that was a very, very interesting presentations. I want just to thank all the speakers for very interesting presentation, but also to congratulate all of you for all this fantastic work you are doing. I hope to see you again next year in Romania. And thank you also to all the delegates. We have been over 100 people on the session for most part of the session. I think almost 117 people here together listening to these fantastic speakers. So just a reminder, at 4 o'clock, there's the last plenary session. I hope to see all of you there and you enjoy the rest of the conference. Thank you very much, everyone. Bye now.
Bye-bye. Thank you. Bye-bye.